Hi guys, today's topic about Frey syndrome, or you can say this is gustatory sweating or auriculotemporal syndrome. So this Frey syndrome, also known as gustatory sweating or auriculotemporal syndrome, it is sweating, burning, and warmth over parotid region, means preauricular region after parotid surgery, TM joint surgery, and parotid trauma. So this is sweating, burning, and warmth over the parotid region after parotid surgery, maybe after TM joint surgery, after parotid trauma. Most commonly after parotid surgery. So this is flushing, sweating, burning, and warmth. So this, how this happens? You know, parotid gland supply by the postganglionic fibers of auriculotemporal nerve, and this is the gland this gland supplied by these fibers of the ATN, and skin over this skin having sweat glands. This sweat gland supplied by the sympathetic fibers. What happens after surgery? You are elevating this flap of skin and you are removing this parotid gland. So these fiber of ATN, after surgery, there is no parotid gland here supplying these sweat gland. So this is because of misdirection, renervation of sweat gland and skin of parotid region by the fiber of auriculotemporal nerve. That's why this happen. But exact pathology is not known till now. It is unknown till now. So this is the pathogenesis of the auriculotemporal syndrome. Most of the auriculotemporal syndrome occur after 1 year because this is the average time. But it can happen between 5 weeks to 5 years. In between, this is the common duration period in which this Frey syndrome occur after parotid surgery. But sometimes it can occur 12 to 30 years. Some patients have seen after 12 to 30 years of the parotid surgery. Now, what is the diagnostic test? Diagnosis. Most common diagnosis is clinical. You can have history of parotid surgery and flushing and sweating over the this parotid region. And Gold standard test is minor iodine starch test. This is the gold standard test. If you apply the iodine over the preauricular region or parotid area, if you give some lemon or any food for chewing, then there is sweating, means there is bluish black area over preauricular or parotid region. So gold standard is minor iodine starch test. Now how to treat? Treatment. If mild symptoms are there, then you have to reassurance and observation. You just reassure the patient that this phenomena is common and you have to observe sometime, it will goes away. So this is if mild symptom or no symptom is there, even after parotid surgery, almost every patient's having some sensation or symptomatology over this uh, pre-auricular region or parotid region, some symptomology always there of this parotid surgery. It may be numbness, warmth, flushing, or sweating, because this innervation is always happens. So some symptomatology is always there after parotid surgery. So you just make them reassurance and observation. You can add scopolamine and glycopyrrolate therapy. Glycopyrrolate 1 milligram BD dose you can add in the mild symptoms is there. If moderate to severe symptom, a patient complaining there is moderate to severe symptoms, then best therapy is the botulinum toxin injections. Injection over the parotid region in subcutaneous space. You can give 5 to 10 units in that area. It will work up to 1.5 years in 60% of the cases. So this single injection can work up to 1.5 years in 60% of the cases. Now, what is surgical treatment? Surgical treatment. Best treatment during surgery, you can put, if there is thin skin is there, thin flap over the parotid is there, you can put sternocleidomastoid flap interposition between the skin and the remaining parotid bed. Or you can give temporalis muscle or temporalis temporoparietal fascia flap. So these you can overlap over the temporal this parotid bed during surgery. Then that is preventive measures. After surgery, you can have this sternocleidomastoid muscle flap or temporoparietal fascia flap overlap the parotid bed. Between the skin and parotid bed, you can put this flap. Another therapy is tympanic neurectomy. What is tympanic neurectomy? It is tympanic plexus which is situated over the promontory of the middle ear. This tympanic branch coming from inferior tympanic canaliculus from the glossopharyngeal nerve coming into middle ear, forming the lesser petrosal nerve. Why? Some fiber from facial, some fiber from this vagus are not nerve, and main fiber coming from the this tympanic branch. Tympanic branch is the branch from the ninth cranial nerve, glossopharyngeal nerve. This tympanic plexus situated over the promontory in the middle ear, and you just have to elevate this TM flap, tympanomeatal flap, and after elevating this, you have to cut this CV of this nerve about 3 mm. Cut is you have to cut both and gap should be minimum 3 mm. After cutting this, you can cauterize these ended or plexus of this. So this is also very effective therapy. This tympanic neurectomy also done in siloria. Other indications of tympanic neurectomy is siloria, chronic parotid fistula, and sometimes chronic parotitis. Parotitis. So this is can be done in the siloria, chronic parotid fistula, or chronic parotitis. And best indication of tympanic neurectomy is the Frey syndrome. Now, related syndrome to this is first white syndrome. Just brief about first white syndrome. This happens because of damage of sympathetic fibers of this region, means parotid region, and this is what there is severe throbbing electric like pain over preauricular area during first bite of meal. If you are taking any meal, this is happening severe throbbing electric light pain over preauricular area during first bite of meal. This happens because commonly after deep lobe parotidectomy, parapharyngeal, parapharyngeal tumor surgery, or TM joint surgery. So this first white syndrome commonly occur after this deep lobe parotidectomy, parapharyngeal tumor excision, and TM joint surgery. This is happened because damage of the sympathetic fiber and overactivation of auriculotemporal nerve fibers, means overactivation or over renervation of the auriculotemporal nerve fiber to the this area. This lead to the sensory activation. Sensory activation leading to pain in this area. So most of the time, this first white syndrome cure by the reassurance. You just reassure patient this pain will be on the remain sometime on first white only. Reassurance, and treatment is mainly any neuropathic pain first line therapy is the gabapentin or pregabalin is the first line therapy. You can give carbamazepine or oxcarbamazepine can be given, and you can give Botox therapy if there is severe to moderate first white syndrome that decrease the postganglionic parasympathetic drive, which is the main cause of this pain. So you can give Botox injection also. So this syndrome is related. That's why I cover this first white syndrome here in Frey syndrome. Thank you so much.